Topic is pathology of stomach. Okay. So, recap on anatomy of the stomach. So, this is the cardia where you find the mucosal cells, and the fundus where parietal cells which secrete acid and teeth cells which secrete pepsin are present, and the body of the stomach, and the antrum, that is the mucosal cells, and G cells which secrete gastrin are present, and we have the pylorus, and of course continues with the duodenum. And here you find cells. This is the stomach histology, and the surface epithelial cells, they go down into the deep, and in the pits there are mucosal cells which secrete mucus, and then the parietal cells and the are present within between teeth cells also, and pepsin acid are being secreted. So this is a clinical scenario. A 52 years old male is a known alcoholic. So whatever topic I am like gastritis or peptic ulcer I am discussing, I won't be discussing the clinical features. All the clinical features will come in the case scenario. Okay. So he's a known alcoholic, presented to the medical OPD with history of epigastric pain in the epigastrium on and off, also nausea, vomiting with occasional hematemesis. So on examination, there is tenderness in the epigastric region. So this is how the clinical presentation of the following disease occurs, lesion. So gastritis, this is a gastritis. So we have acute gastritis and chronic gastritis. What is acute gastritis? That there is inflammation. Of course, we all know itis means inflammation. A stomach, and when acute presentation, and this is a chronic presentation. Of course, the histology also in acute gastritis, the cells are different, and in chronic the cells are different. So in acute gastritis, it's an inflammation of the gastric mucosa, but neutrophils are present. And when neutrophils are absent with inflammation, we call it gastropathy. Okay. So as we look up in the case, it can be asymptomatic, epigastric pain, nausea, vomiting can be there. And there may be mucosal ulcer, there's a spelling mistake, erosion, hemorrhage, hematemesis, melena. How does melena occur? The blood that the hemorrhage in the stomach gets into the stool, okay, altered by the acid secretion. So what are the etiologic factors? The first and foremost is NSAIDs, non-steroidal anti-inflammatory drugs, and corticosteroids. Second is alcoholism, smoking, and bile. How does bile enter the gastric? Some reflex, or when some portion of the antrum or something is being removed, the bile gets it back into the stomach. So it is a reflex. Then shock, that I will come to, and uremia, acid alkali exposure. How does this happen? I mean, mistakenly or for suicidal attempt, this is being consumed. All of this are etiologic factors for acute gastritis. So how does the pathogenesis occur? So pathogenesis, this is the normal structure as we saw. And what are the protective factors in the epithelium? or in the stomach wall. So it is the surface mucus secretion, a layer of mucus coating the mucosal cells. So that forms a barrier between the food products or whatever we consume and the mucosal cells. This forms a barrier between both so that mucosa is not destroyed. Second is bicarbonate secretion that gets into the mucus, and important factor is mucosal blood flow. The blood oxygen and nutrient supply through the mucosal vasculature is very important. Then this epithelium forms a barrier function. Then, as we all know, the epithelium gets destroyed, denuded, and more amount of regenerative epithelium is being formed. That capacity of it, maybe in the old age, that will be reduced. Then prostaglandins. Why these prostaglandins are important, I'll tell you. And so these are all very important. The mucosa, muscularis mucosa, and the submucosa all have some role in this protective action. And what are the damaging factors? What is the pH of the gastric juice? That is about 1. 1 is highly acidic. So because of this mucus, because of the bicarbonate secretion, because all of that, the gas, that is, these mucosal cells are being protected. And peptic enzymes, that is also a destroying factor. Then there is injury, that is, the protective factors are less or deranged, and the damaging factors take an upper hand. That time injury happens. So what are the protective factors that are deranged? Ischemia, the mucosal blood flow is reduced, so oxygen and this nutrient supply is reduced. Then shock, there also the blood flow is reduced. NSAID consumption, that will interfere with prostaglandin elaboration, as well as they damage the mucus bicarbonate complex in the mucosa. So because of then what are the injurious agents? NSAIDs, tobacco, alcohol, what all we saw in the etiologic factors, and duodenal gastric reflux and gastric hyperacidity. And if we leave this alone, there is some edema, some mucosal damage that is happening. So this is a long pit has been narrowed and widened and shortened, and the mucus, this thick mucus is being reduced here in gastritis. But when this prolongs, these injurious agents are prolonging, then the ulcer develops. Okay, ulcer. So here we don't find any mucosa. Completely the mucosa is being damaged. So this is a process from gastritis to ulcer. I'll tell about the layers when we discuss ulcers. So what are the secretory tissue, protective factors, injurious, and the conditions? So the foveolar cells secrete mucus and phospholipids. They combine and have a protective effect. So what happens is the NSAIDs, when they cause prostaglandin, COX-dependent prostaglandin E2 and E1 to I2, E2 and I2, these are being inhibited. Okay, this prostaglandin is being inhibited by the NSAIDs. So because of that, this mucus and phospholipids are being damaged. Second is the surface epithelial cells secrete bicarbonate ion. So in uremia, as well as in H. pylori infection, where the urease is present, from the ammonium ions cause are the injurious ions that are being produced in uremia and H. pylori infection, and that will reduce the bicarbonate ion secreted by the surface epithelial cells. And of course, the mucosal vasculature that is responsible for the production of supply of oxygen and nutrients. And that will be when it is reduced in older age or when the person goes for high altitude, etc., that there is reduced blood supply. So this oxygen and nutrients are reduced. Because of that, the acidity overwhelms. Okay. And the acidity overwhelms, and because of all these protective mechanisms are lowered and the injurious events are happening, the gastritis occurs. So initially it is acute superficial gastritis causing inflammation of, I showed you the picture, inflammation of superficial gastric mucosa. Then it goes to erosive gastritis where multiple small zones of superficial mucosa occurs, then leads to acute gastric ulceration where you see full thickness of the mucosa is damaged. Okay, that happens in ulcers. So grossly, how does it appear? If it is this type, destruction of multiple small zones of superficial mucosa or superficial gastric mucosa, that this will resemble like this. So what are the cardinal signs of inflammation? You remember the cardinal signs. Same happens everywhere, even if it is an organ also, same signs. So edema. So because of edema, the mucosa is being edematous, and you can find that, and small white deposits are being seen because of the inflammation. So this is a erosive gastritis where you can find multiple small ulcers and the basis little bleeding is there. That is why it is black in color. The acid that is produced by the secreted in the stomach combines with this blood forming the black colored pigment. And histologically, what do you see here? So here there is edema, the cells are apart, these are the glands, and we see inflammatory infiltrate. Okay, here what happens? The mucosa is being denuded. It is again super, and there is inflammatory infiltrate. These are the glands, surrounding that is the inflammatory infiltrate. What is the inflammatory cell? Neutrophil. Okay, and to a certain extent lymphocytes, plasma cells can be seen. And what is stress erosion or stress ulcer? This happens mainly in critically ill patients, and in ICU this is more often seen, and people who are on shock. We saw shock as one of the etiologic factor for gastritis and ulcer. So what happens here? There is shock, there is hypovolemia, blood supply to the stomach or non-vital organs are reduced. So stomach gets less blood supply, and because of that, there is mucosal vasculature cannot supply oxygen and nutrients enough, and acidity overruns. Then sepsis, trauma, same pathology. And in burns, again the same. And when stomach ulcers occur due to burns, it is called as curling ulcers. And in people with intracranial disease, when they get same kind of ulcers, it is called as Cushing ulcers. And this pathogenesis is different. So here, when there is a intracranial disease, the vagus nerve is stimulated. That causes increased secretion of gastric acid, leading to Cushing ulcer. and chronic gastritis. Up to this is acute and chronic gastritis. This is very important. So for the development of peptic ulcer to carcinoma, lymphoma, for all that, chronic gastritis is a precursor condition. So what is the definition? It is a chronic inflammatory infiltration of gastric mucosa. So gastric mucosa is inflamed. There is inflammatory infiltrate. So mucosal gland, what will happen to the mucosal gland? There is atrophy and epithelial metaplasia. So what metaplasia occurs? Intestinal type of epithelium. The stomach epithelium can withstand acid, but intestinal epithelium cannot withstand acid. Okay. Usually in the absence of erosions. So there is no erosion and epithelial cells may become dysplastic. You know what is metaplasia and what is dysplasia. This dysplasia is a precancerous condition and constitute a background for the development of carcinoma. So there is some inflammation, there is mucus gland atrophy, epithelium undergoes metaplasia and dysplasia, going on to progress into carcinoma. What are the types? There are three types: Helicobacter pylori gastritis, autoimmune atrophic gastritis, and uncommon forms of gastritis. So what is H. pylori gastritis? So here, this H. pylori, all of you know about the structure. I'm not going to the detail. It gets into the stomach by fecal oral route. So because of that, lower socioeconomic group, so many things are said, and they colonize within the stomach for a long time. Maybe from childhood, they will be just sitting over there. They are very comfortable in the mucus of the stomach. They will be there doing its own work over there. Then after a long time, this will produce chronic gastritis, then the other malignant conditions. Okay. So you initially it is, so how does this is happy in the stomach? So this H. pylori has got adhesin that will adhere to the mucosa. Then this has got flagella that helps in motility and chemotaxis. And again, it has some lipopolysaccharide that will adhere to the stomach mucosa. Then it secretes urease that neutralize the gastric acid from pH 2 to 6.1. Okay. So this is very important. So that pH 1 or 2 is the stomach, pH of the stomach, gastric juice. From that it goes to 6.1. And the flagella, and it has got a exotoxin that is called BAC-A. Also, there is associated with this cytotoxin is a cytotoxin associated gene A, otherwise called CAG-A, C-A-G-A, cytotoxin associated gene A. This is the exotoxin, and this will cause injury to the mucosa, and with this is associated the cytotoxin associated gene A. So initially it colonizes in the antrum and cause gastritis in the antrum. So once there is inflammation, their acidity reduces, then increased gastrin is being secreted. And because of increased gastrin secretion, the parietal cell's hyperplasia occurs and more of acid is being secreted. Then when it stands for a long time, this becomes a pan-gastritis. Anywhere in the stomach, gastritis can occur. That will cause atrophic gastritis. That time, this parietal cell mass gets reduced and the cells undergo metaplasia. The mucosa undergoes metaplasia, intestinal metaplasia. Remember, initially it is antral gastritis. That time there is increased gastrin secretion and increased parietal cell mass leads to increased acidity. When it is of long standing, the mucosa atrophies and parietal cell mass is reduced and the mucosa undergoes intestinal metaplasia. So how does this progress? There are bacterial and host factors. So this is the H. pylori. With H&E stain, we see like this, like roughly we can see like this. And with Giemsa stain, the organisms are seen in the over the mucosa. And this is a silver stain. With this, we can clearly see the organisms. And what is the sequelae? What are the factors? So this is the H. pylori. And what are the host factors and that will determine the sequelae of the disease. So here the host factors like gene polymorphism or immune response, host immunity, as well as the other factors which contributed to acute gastritis like NSAID, proton pump inhibitors, alcohol, smoking, all that put together, will decide how is the sequel. So first is high acid production, as I told you, that is the antral predominant gastritis. This, if left over, the complication of it is peptic ulcer disease. Okay. And as such, this will cause chronic gastritis. And when it produces high acid, it is a peptic ulcer disease. When the acid production is lowered, it goes here also pan-gastritis, and that is atrophic gastritis that leads to gastric carcinoma. Okay, now understood the sequelae. So there are bacterial factors like structure of the bacteria. The flagella is important, the adhesins, the porins, the enzymes, urease, and VAC-A, exotoxin, and CAG-A, the gene, all that matters. And the host factors, how long the H. pylori is there in the stomach and where is it situated, like in the antrum, or it has gone to fundus and the body also. Then the host inflammatory response and the genetics of the host. Okay, so how is this, which one is increasing? Depending on all these factors, it can be just a chronic gastritis, that's all. Or it may progress to peptic ulcer disease, or it may progress to gastric cancer and gastric malt lymphoma. So if a question on H. pylori induced lesions are asked, it can be chronic gastritis, peptic ulcer disease, gastric malt lymphoma, or gastric cancer. So under histology, so this is a pathology paper. So some histology also must be written. So here the mucosa is flattened. Then there is edema here and lot the organisms here. The mucosa is reduced. Mucus is reduced and there is inflammation. So here also there is a gastric gland surrounded by inflammation. So what are these inflammatory cells? In acute gastritis, we said it is neutrophil. So here, see these cells. What are these cells? These cells are all plasma cells. Okay, these cells are all plasma cells. and some of them can be lymphocytes also. So lymphoplasmacytic infiltrate, lymphocytes and plasma cells. It is a chronic gastritis. Remember that. Of course, some neutrophils can be there. Here it is there. Some of the neutrophils are present, but the predominant one is lymphocytes and plasma cells. Now coming to autoimmune atrophic gastritis. So here what happens is, you all know about autoimmunity and all that. So this is auto antibody to parietal cells and intrinsic factor. Sometimes it may be to canalicular antibody or intrinsic blocking antibody, binding antibody. There are so many things are there. They lead to immunologic destruction of the parietal cells. So against this parietal cells or against the intrinsic factor, antibodies are produced that cause destruction of the parietal cells. So what happens? The pepsinogen is reduced. Okay, pepsinogen 1 concentration is reduced. And endocrine cells, there are some endocrine cells in the stomach, no? They all undergo hyperplasia. So because of this intrinsic factor is essential for vitamin B12 absorption. So there is vitamin B12 deficiency. Then it is called pernicious anemia. 10% of these people develop this pernicious anemia. Acid secretion is reduced and it can be as such, or it may be associated with other autoimmune conditions like Hashimoto's, Addison's, etc. And CD4 cells are important in this autoimmune pathogenesis. And where do you get this? Here, in the body of the stomach. Okay, in the fundus and body of the stomach. So grossly, what happens? Here, what is seen? Here we get the rugae. Rugae are present here, but in this area there is no rugae. It is flattened and smooth. Mucosa is atrophied. So see here, the mucosal atrophy, and there is some actinic cells are seen here, secreting cells, and there is all infiltration by lymphocytes, lymphocytic infiltration. And sometimes we find lymphoid hyperplasia, nodules, all that is seen because of the autoimmune nature. And by immunofluorescence, if you do the antibody, find wish to see that, and this is how they fluoresce the mucosa, all the autoantibodies are being seen. So what are the differences or similarity between H. pylori gastritis and autoimmune gastritis? So what is the location? H. pylori can be start with in the antrum, then move on to pangastritis, whereas autoimmune is in the body. And what are the inflammatory cells? Here neutrophils and plasma cells. But autoimmune lymphocytes, macrophages. And acid production increased, then slightly decreased. Here it is totally decreased. Gastrin, normal or decreased. Here it is increased. Other lesions are, it can form small protrusions called hyperplastic polyp or inflammatory polyp. Here the endocrine cells are increased. Okay. So what will happen? This neuroendocrine tumors can occur. Okay. Neuroendocrine hyperplasia. Serology. Antibodies to H. pylori. Here antibodies to parietal cells are present. What is the sequelae? So this will lead on to what? Peptic ulcer, adenocarcinoma, malt lymphoma. Here, atrophy, pernicious anemia can cause adenocarcinoma, but more common is carcinoid tumor. What is the association? Low socioeconomic status, and a residency in rural area. Here, autoimmune nature like thyroiditis, diabetes, etc. So these are the differences between those two. And common gastritis are eosinophilic gastritis, lymphocytic gastritis, and granulomatous gastritis. I am not going into the detail of it. Just remember that. This is another case. So, what do we learn from here now? There is gastritis, can be acute. Acute can be mainly due to NSAIDs, alcoholism, cigarette smoking, and bile. Don't forget, bile is also important, plus shock. Okay, and the mucus, it can be a superficial or a little erosive or going into a ulcerative kind of thing. And the cells are neutrophils. And chronic gastritis, there are two types: H. pylori, autoimmune. H. pylori is starting in the antrum, going on to the full stomach, leading to intestinal metaplasia, etc. And is a precursor for peptic ulcer disease and maltoma and adenocarcinoma. Whereas that autoimmune is antibodies to parietal cells or intrinsic factor causing lymphocytic infiltration, leading on to neuroendocrine tumors and also adenocarcinoma. So this is the case scenario 2. Is that adult male complains of acute abdominal pain. He had been having epigastric pain for a long time, which is burning and boring. And the pain is worst at night, mostly after food. He finds relief after drinking cold milk. So this contains alkali. So there is some acidity that is relieved by this. He is a smoker and outside food taker. And on examination, he is pale, anemic, tenderness in the epigastric region. Now, all these are his past history, and now he is having acute abdominal pain. So they have taken an X-ray. What do they find? Air under the diaphragm. So there, what is that? Denotes it's a perforation. So he is taken to the theater. So this is peptic ulcer disease. So what is peptic ulcer disease? It's a chronic mucosal ulceration, chronic mucosa ulcerated. It can affect duodenum or stomach. And it is affected mostly with these three things: H. pylori, NSAID, cigarette. Then it can occur in the gastric antrum or in the duodenum. Again, there are balancing factors. The same thing for gastritis, you have to write H. pylori, gastric acid, pepsin, NSAIDs are the factors. They are good. They are the hostile factors, injurious agents, and these are the protective factors: bicarbonate, prostaglandin, mucus production, and blood flow. So when this is increased like this, that will cause peptic ulcer formation. Okay. So what are the risk factors for peptic ulcer disease? Already we learned H. pylori, cigarettes, COPD, drug usage, NSAID, alcoholism, and psychological stress. How does that cause? That increases gastric acid secretion. Then endocrine cell hyperplasia. What will be secreted? Lot of gastric acid. Then Zollinger-Ellison syndrome. Okay. And viral infections can also cause that, like CMVD, and cytomegalovirus and herpes simplex virus. So how does this appear? This can occur in the proximal duodenum and mainly lesser curvature, more common in the lesser curvature. It can be solitary or multiple also. 80% is solitary and 20% can be multiple. And it is a round to oval ulcer and sharply punched out. You can see punching out. This word should be there. Sharply punched out. Sharp. You can well define sharp punching out. And mucosal, this mucosa, when you see histology, it is in level with the surrounding mucosa. Okay, that is a very important point. Mucosal margin in level with surrounding mucosa. So what is the histologic finding? This you have to remember. There, this is the ulcer. See here, this is the ulcer gastric mucosa. This is the ulcer margin. So this is going like this. Okay, going like this. And this is the lumen. This is the gastric mucosa. Here there is some inflammation, chronic gastritis, and this is the ulcer margin. This is the ulcer base. So what is this ulcer having? What are the zones? So here there is a fibrin, superficial thin layer containing necrotic material, fibrinoid necrotic material. Then there is a zone of inflammation. So here infiltrated with neutrophils and sometimes some lymphocytes also can be seen. Beneath that is a granulation tissue. And the granulation tissue, of course, you know, there is angiogenesis, fibroblastic proliferation, and some inflammatory cells, all that. Then there is a zone of fibrous tissue or collagen formation. So these are the layers. Remember, thin layer of fibrinoid debris, neutrophilic infiltrate, granulation tissue, and fibrous scar. So what will happen when the fibrous scar appears? There is cicatrization. And before that, if it happens, what will happen? It perforates. Before the fibrous scar is being formed, or if it is weak, there is perforation. In this man, what we saw in the case, it has perforated, that caused leakage of, that is why the x-ray showed he had acute abdominal pain and x-ray showed air under the diaphragm. What are the complications? Bleeding from the ulcer that were maybe small, leading to melena, or that can be a massive hematomesis, perforation, as we discussed, obstruction because of the thick fibrous tissue. Then mucosa may get atrophy and intestinal metaplasia. Remember that this is very, very important. That's metaplasia, dysplasia, and sometimes small cyst kind of that epithelial cyst can be formed. This is a very interesting case. He is a conqueror. So what did we learn? Peptic ulcer disease that can be in the duodenum or in the stomach, a sharp punched out ulcer. The etiologic factors are similar to the gastritic factors, and a balance between protective factor, imbalance between the protective forces and the injurious agents leads to peptic ulcer disease. And a punched out ulcer, and there are 4 layers at the ulcer base, and complications are mainly bleeding and perforation, and mucosal atrophy and intestinal metaplasia leading on to dysplasia. So he is a conqueror of most of the Europe. He suffered from loss of weight, anorexia, altered bowel habits. He also had dyspepsia. Dyspepsia means the like peptic disease. Then dysphagia, not able to eat properly. Then tiredness. Then he died at the age of 52 years at St. Helena in 1821. He was not examined, though he had all this. If he would have been examined, he must have had anemia. And that time, during this period, USG was not available. And he may be having a growth in the gastric antrum. Who is he? And always he keeps his hand over his abdomen. That is because of his discomfort. But people thought it is something custom. So he is Napoleon Bonaparte, and he had died of gastric cancer. And his father also had similar symptoms, maybe suspected gastric cancer. And this is a pedigree. And another person also died at 56 years in his family. So from this, what do we learn? Why did he die? Can be diet full of salt preserved foods, because he was in the military. So, and fruits and vegetables were so preservation, salted, preserved food, and genetic. So diet is one of the factor. So from this we are learning something. Genetic factor. His father also had, and one of his sibling had. Then H. pylori. He was chronically infected, okay, with H. pylori, because he had long duration of dyspepsia, all those things. Then precancerous changes, chronic atrophic gastritis. So these four factors are important for the development of gastric cancer. So gastric adenocarcinoma is very important. 90% of the gastric cancers are adenocarcinoma. There are two types, intestinal type and diffuse type. So how does it differ? This is associated with, remember, chronic gastritis, all that peptic ulcer disease we have been telling, intestinal metaplasia, dysplasia. So this arises from metaplastic gastric mucosal cell, and this is better differentiated. You are able to find the glandular structures. And diffuse, this doesn't arises from the native metaplastic cells. It is neither associated with chronic gastritis, and it is poorly differentiated. You may not be able to find out the um, you may not be able to find out the glandular structures. So what is the epidemiology? Japan, more common because they are fond of the smoked food. Okay. Smoked fish, they eat lot of smoked fish. And this Kyle, Eastern Europe, Africa, and Southeast Asia also. Nowadays, everywhere it is present, and it is common in, it is not so. Napoleon Bonaparte was not belonging to lower socioeconomic, but he had some genetic history. Then multifocal mucosal atrophy, intestinal metaplasia, people who have this run a risk. Smoked food, dietary carcinogens, refrigeration, preservation. All this are risky factors. Then Barrett esophagus, chronic gastroesophageal reflux disease. So this is also causes gastric cancer. Then obesity. Obesity causes chronic GERD. So the pathogenesis for both are different. For the diffuse type, it is the E-cadherin loss. Remember, E-cadherin loss is the key step for developing diffuse gastric cancer. So how does this get lost? This germline loss of function mutation in the tumor suppressor gene CDH1. So the tumor suppressor gene CDH1 has germline loss of function mutation that leads to E-cadherin loss. That is the key step in development of diffuse gastric cancer. So that can be either familial or sporadic also. Whereas for intestinal type, it is increased signaling via the WNT pathway, and or loss of function mutation in APC gene or gain of function mutation in gene encoding beta-catenin. These two can also occur. So there is WNT pathway for intestinal type and E-cadherin, you remember, for diffuse type. loss of function mutation for APC gene, gain of function for beta catenin encoding gene. So these are the things. I'm not going to details. So this is the normal gastric mucosa. Here there are chromosome 17q21. There is a P53 mutation and CDH1, CDH2, all that. CDH1 causes key catenin mutation, leads to diffuse type gastric carcinoma. This normal gastric, so this trait with all this occurring here, genetic or molecular events happening, this trait goes into diffuse type gastric carcinoma. Whereas in this type, intestinal type, there are some steps. Normal gastric mucosa with H. pylori or genetic instability, all that put together causes chronic gastritis. Then you have CDH1 mutation, atrophic gastritis, then intestinal metaplasia. Here comes APC mutation, KRAS mutation, P53 mutation, and that will cause adenoma or dysplasia, then intestinal type gastric carcinoma. Morphology, there are 4 types. One is polypoidal. You know about polyp, no? Polypoidal. Fungating. The polyp becoming very large, like cauliflower kind of thing. Then this is a ulcerated type. Next is diffuse infiltrative type. See here, type 1 polypoidal. The polyp like this, standing out. And the fungating type like this. Okay, grossly it appears like fungating. Third is ulcerative, a large ulcer. Here you have to find, it's not punctured. There is the mucosa over that is overlapping. Okay, overlapping. Then there is infiltrative. Here you see the wall is being thickened because of the infiltration. Linitis plastica. The stomach looks like a leather bottle appearance with thick wall. So histologically, in intestinal type, what did we learn here? There is associated with chronic gastritis, then arises from metaplastic gastric mucosal cell. I showed you, better differentiated. This you cannot differentiate, okay? So here, there are some glands. There is a mucosa. Of course, there is metaplasia, dysplasia. The perfect mucosa you are not able to see. And there is breach in the muscularis mucosa, and you find lot of glands, infiltrating glands. They vary in size and shape. They are all looking malignant. The individual cells show pleomorphism. There is more than one layer, and infiltration of the cells are also seen. But some glandular preservation is present. So it is differential, intestinal type. Whereas in diffuse type, see here, what are these cells? They are resembling like vacuolar cells, but it is not vacuolated. The mucus is present within these cells, and the nucleus is pushed towards the periphery. They are called signet ring cells. Okay, signet ring cells. So that is that linitis plastica, diffuse type. So where does it spread? Carcinoma stomach. So regional lymph nodes, liver, and it can infiltrate into the pancreas also, and left supraclavicular node, that is called as Burgos node, and Sister Mary Joseph nodule, umbilical nodule, and into the ovary through peritoneum. So peritoneal seedlings can be present, Also, it can spread to the ovary, usually bilateral, and it is called as Krukenberg tumor of the Krukenberg tumor. It is the coelomic spread. You must have read during metastasis in the carcinoma chapter. Okay, malignant in the general pathology. So regional lymph node. So there is infiltration. This direct infiltration can happen. Lymph node spread can happen. Okay, lymphatic spread can be there, and hematogenous spread as well as coelomic spread. All that can happen in gastric carcinoma. Next is gastric lymphoma. So lymphomas usually occur in the lymph nodes. There are some extranodal lymphomas also can happen, and stomach is the most common site. So what is the most common type? Indolent. Indolent means it is not responding to therapy, not progressing, not aggressive also. Indolent, extranodal. It is not in the lymph node outside. It is in the stomach. Marginal zone, B cell. B cells of marginal zone type lymphoma. So, indolent, extranodal, marginal zone B cell lymphomas. They are previously called as maltoma, mucosa associated lymphoid tissue, tumor, lymphoma. And other tumor that can occur is diffuse large B cell lymphoma, and this can progress to DLBCL, or DLBCL can occur as such. And this stomach doesn't have, like intestine, the stomach doesn't have that lymphoid tissue. Okay, now remember that. So malt, how does this mucosa associated lymphoid tissue happen in the being formed in the stomach? That is by chronic gastritis. Remember the what is the pathogenesis? In H. pylori, it is antibody to the H. pylori can induce lymphocytic infiltration, and in autoimmune gastritis, the antibody to parietal cells and intrinsic factor can produce lymphocyte accumulation. So malt is produced in chronic gastritis. And how come the become tumor lymphoma is they say that translocation of chromosome 3 translocations may be the etiologic factor. I'll tell about the translocation, and all the three, and also activation of nuclear factor kappa B, that is also important. So what are the 3 translocations that happen? So translocation 1118. So in 1118, there is API2 and malt. API2 is present in 11 and malt1 is present in 18. So when they both fuse together, fusion protein is formed, and that is responsible for most of the lymphomas. So that can be detected by fish or karyotyping. The other is translocation 1418. Here also that MALT1 is present. So this MALT1 is overexpressed. Because of that, the lymphoma arises. This is translocation 1 with 14. This 14. So BCL10 is overexpressed. Okay. So these 3 translocations you remember. Also the activation, they all lead to activation of nuclear factor kappa B, leading to so morphology, all of us know, no, lymphoma, it is a fleshy tumor, smooth, glistening, all that. Okay, so the tumor is present like this. It is usually ill-defined, smooth, glistening, and fleshy in appearance. And this is the mucosa. Here you get a lymphoma tissue and it is infiltrating into the mucosa. And this terminology you have to remember. It is a lymphoepithelial lesion. So the glands as well as the mucosa are infiltrated by that malignant or malignant lymphoid cells. Okay, the mucosa glands as well as the epithelium are infiltrated by these lymphoid cells. That is lymphoepithelial lesion. This is very important, this terminology. So how do you assess that? It is a B cell neoplasm. Remember B cell. So when we do the pan-keratin, all the epithelium will be stained by immunohistochemistry. So these are the stained areas with pan-keratin. So what are the unstained areas? All are lymphoid, malignant lymphoid cells. So see here, this is CD20. That is expressed by B lymphocyte. CD20 is expressed by B lymphocytes. So all these are the lymphoid. So now are you convinced it is a lymphoepithelial lesion? So all these are going into the epithelium. And next is neuroendocrine neoplasms. These arise from the diffuse, though endocrine organs have this, and it is throughout the body somewhere that endocrine cells are present. And from that small components, this neuroendocrine neoplasms arise. And the GI tract is the common, but most of them occur in the intestine. And but it can happen in the stomach also. It is usually associated with endocrine hyperplasia. Where endocrine hyperplasia, I told you, it happens in autoimmune gastritis. Also, Zollinger-Ellison syndrome, where the gastrin is secreted more, and Menwen syndrome. So, how does this patient present with? This tumors secrete peptide and non-peptide hormones. So whatever hormone is produced, that hormone overreacts and the symptoms are according to the hormone. Okay, that effect usually. And these tumors are present intramural or submucosal. And always remember, neuroendocrine tumors are yellow to tan and they are firm in consistency. And it is in the intramural or submucosa. So mucosa may be ulcerated. And the cells may occur like island or forming trabeculae or small file kind of things, strands or glandular pattern or in sheets. And all cells are uniform. And there is pink granular cytoplasm because they contain that secretory bodies. Then round to oval nucleus and the chromatin, salt and pepper chromatin. And whether this is neuroendocrine neoplasm. I haven't put malignancy. So when does carcinoma arise or they progress to carcinoma? When there is high mitotic rate and K67 proliferation, the mitotic index, proliferative index are increased, it is neuroendocrine carcinoma or infiltration is there. And how come the benign tumor progresses to malignancy or malignancy arises as such is this mutation, TP53 mutation and RB gene, all tumor suppressor gene mutation occurs, malignant progression to malignancy occurs. So this is a tumor, the yellowish tan, and it is sharp, and these are the uniform cells with salt and pepper chromatin. Okay, and what are the IHC? Chromogranin A that confirms the diagnosis, Synaptophysin also confirms the diagnosis, and CDX indicates it's of bowel origin, and CD56 and NSC are less specific markers. And finally, gastrointestinal stromal tumor, otherwise called GIST, gastrointestinal stromal tumor. It is the most common mesenchymal tumor of the abdomen, and among this, more than half of them occur, 50% occur in the stomach. What is the cell of origin? The interstitial cells of Gajal or pacemaker cells. How does this tumor arises? Because of gain of function mutation of the gene encoding tyrosine kinase receptor or c-KIT, what we call it. Because of this gain of function mutation, the tumor arises from the interstitial cells of Gajal or pacemaker cells. And the IHC for this tumor, immunohistochemistry for this tumor, marker for this tumor is CD117 or c-KIT. We call it CD117. This tumor can be silent, small microscopic size to progression, or it can become overt GIST and causes obstructive symptoms. So how does this progression occurs? It is due to loss or partial deletion involving chromosome 9, 14, 22. So all this chromosome, where do you come across? Remember CML? So the same treatment, imatinib is the treatment for this. Okay, tyrosine kinase inhibitor. Morphologically, this can be a large tumor and a fleshy tumor, smooth with whorled appearance. Whirling will be there. And if there are two types, histologically, spindle cell type and epithelioid type. So this is the mucosa and tumor arises from here. And these are the spindle cell type. Spindle cells are elongated cells with smooth borders, okay, that is spindly, we call it, with pointed ends. That is spindle cells, and because of these cells, it is of whorled appearance. And epithelioid types, like epithelial cells, they are polygonal cells with eosinophilic cytoplasm and a dark nucleus. These cells have scanty cytoplasm and a spindled nucleus, elongated nucleus. And there are some syndromes associated with GIST. Carney triad, there GIST, pulmonary lung chondroma and paraganglioma occurs, and that is not inherited. Carney-Strataki syndrome, there GIST and paraganglioma, and which is inherited and autosomal dominant with incomplete penetrance. To summarize, gastric adenocarcinoma forms 90% of gastric malignancies. Lymphoma constitute about 5%. The remaining 5% is due to GIST, neuroendocrine carcinoma, leiomyosarcoma, and any neural tumors, lymphangioma, all that tumors can arise. Then gastritis is of infective type, where H. pylori is the organism, or autoimmune type. And H. pylori induced type is a precursor for malignancy and lymphoma. And atrophic gastritis is the important one, leading to peptic ulcer disease, maltoma, and of course, gastric adenocarcinoma. Thank you. Any doubt? Any doubt? Anybody? Any doubt? Shweta?
No, ma'am. It was
Okay.
a great class.
Yeah.
Thank
Bye.
you, ma'am.
Bye. Bye. Thank you.